So this video is going to demonstrate assessing for tone in the lower extremities. I've chosen to have my patient laying down because it's a lot easier for them to relax in supine. It's easier for me to move their leg through full range at the hip as well as at the knee and the ankle, which can be done easily in sitting as well. The principles are the same. You want to make sure that you check their available passive range first. That can be part of your slow motion testing. And then once you're familiar with the range that's available, you're going to quickly move them through that available range to see if you detect a catch or if you perceive some increased resistance throughout the range, which might suggest rigidity. The quick catch is more of a spasticity sort of component. And keep in mind that the first pull or the first quick stretch or the first, aggressive movement through range of motion is usually the most accurate reflection of their underlying spasticity or tone, because as you continue to go repeatedly through their range, that can reduce the amount of tone that they have. In fact, that's an intervention to try to reduce tone, is just some gentle passive range of motion repetitively. So I'm going to demonstrate a few times so that you can see the speed and the range and the amount of motion that I'm moving through. But keep in mind that usually the first pull or the first quick stretch is going to be the most accurate representation of their baseline tone. So just for viewing purposes, I'm going to come back here. I would be testing both legs. So my first assessment is moving through the available range so I can see how much motion is available into rotation and abduction as well. I am simultaneously getting ankle range as we're going, and I know when I come back down, he's got good plantar and dorsiflexion. So from here, I'm going to move quickly into testing for tone. I can do a reflex test and look for clonus, give him a quick stretch. Notice that I'm putting some pressure through the ball of his foot. I have his knee bent. I got a little bounce there. Maybe you got to see that at home. So the idea is by putting his knee in a little bit of flexion, I have more available range. When I give him the quick stretch, I maintain the pressure at the end of the range so that I can feel if he has that reflexive beat down. If I maintain the range and he has clonus, he may continue to beat, and again, I can feel that through my hand here. Usually there's no tone in the dorsiflexors, so I rarely go in that direction. But as I go up the chain, I'm going to now look at the knee. So I want to give the hamstrings a quick stretch. Again, if somebody's got tight hamstrings, I'm going to keep them down here. Maybe just let them bounce into full extension. I can bring their knee up and let the foot drop. So the weight of the leg gives the quads a quick stretch. They might catch and then continue to fall. Up at the hip, again, I am going to let the leg come down quickly. So that's stretching the hip flexors. I can do a quick knee to chest to look at the hip extensors. But most importantly, I will let the leg fall to the side to look at the adductors. Those are a common muscle for spasticity in the extensor pattern, which we'll talk about more in the stroke and brain injury lectures. So basically, I've just managed to go through the major muscle groups. Keep in mind when you're doing a quick stretch, which muscle it is that's actually being stretched. So if you detect a change or some resistance, you're documenting appropriately which muscles have tone. And if you are considering whether they have limited range due to spasticity or due to contracture, the Tardot scale helps make that comparison by looking at their full passive range of motion compared to where the first bit of a catch might be moving into their available range for passive range. If there's a big difference between the catch and the final range of motion position, that suggests there's spasticity, so you might recommend antispasticity medications. If the catch and the end of the passive range are roughly the same, it's probably contracture, and you may be considering things like serial casting, dynamic splinting, or even a tendon lengthening procedure. So the treatments are different depending on the conclusion you're drawing from your passive range of motion testing and tone assessment. That is creaky.